Hi, I'm Leonardo Rangel. I'm a head neck surgeon in the State University of Rio de Janeiro, Brazil. It is a pleasure to talk to you guys today about those thyroid cancers and the future of treatment of those cancers. There are several things that are going to change in the near future. So I think it is important that patients know what are coming and the options that they may have. Okay. So this is my conflict of interest. I'm head of a course on radio frequency treatment and also on those endoscopic thyroidectomies. I'm a speaker for several companies regarding thyroid tumors. Okay, so let's talk about those endoscopic thyroids. Well, as you know, having a thyroid nodule, it is very common. Sometimes the nodule is suspicious and sometimes is already a cancer and we know it before surgery. So probably in those cases, surgery will be the most common option for treatment, okay? And the least or the smallest or the less aggressive surgery that we can think of, it is at least a lobectomy. So we have a thyroid nodule here on the sorry on the right side, and we will remove this right side from the thyroid. Uh, Surgeons, anatomists decided that thyroid has a right and left lobe. Thyroid is one big gland, it's the largest gland that we have in the body. So we decided to divide it in those two sides just for better study, but the thyroid tissue is just one. So having a thyroid nodule on one side, we can remove that one side and try to preserve the other side in order to thinking on preserving the thyroid function. Okay, but we also may be concerned on having another cancer on the other side. But just to have this in mind that the thyroid is just one gland. Okay, this gland is cascaded inside the neck, so it is above the thyroid, the trachea, and the vocal box, but it is also very engaged by several muscles on the anterior neck. So very large muscles that will protect the gland, and sometimes will make it difficult to palpate a nodule or something like this. So those muscles are also in front of the thyroid. So when we do the surgery, we have to push those muscles to the side in order to get to the thyroid. Okay, so it is important to remember, since those muscles are part of the movement of the laryngeal tracheal complex that we move while we swallow. So sometimes after surgery, these structures will remain a little bit stiff and stuck to each other. So having sometimes a limitation of the movement just after the surgery. Okay. When we talk about thyroid surgery, we are actually talking about thinking about those complications that we might have on those thyroid surgeries. So I always say to my patients that when we do the surgery, we are not concerned about the thyroid because we know the thyroid will come out pretty straight. We actually are worried about the nerve and the parathyroids. So the recurrent laryngeal nerve, the nerve that will move the thyroid and will give rise to the voice itself, it is very close to the thyroid. It runs below and posterior to the thyroid, and we really need to dissect it and see the nerve in order to preserve it. It goes out of the cranial. It is a cranial nerve from the vagus and makes a curve below the subclavian artery or the aortic uh, artery, and goes back to the neck. So, and goes below the thyroid and posterior to the thyroid. And also those parathyroids. Those parathyroids are small glands that generally are located posteriorly to the thyroid. They are a little bit yellowish, as we see here. They are very important. They co- cover the calcium in the blood supply, so the level of calcium. And those parathyroids, they are very intimate positioned to the thyroid. They are not the same gland, but their blood flow pretty much derives from the thyroid. So when we remove the whole thyroid, we really need to keep in mind to preserve those parathyroids and also their blood supply, not just the keeping the parathyroids structurally, but we need to preserve those blood flow. Okay. The regular thyroid surgery, as most of us know or experience it, are small incisions on the lower portion of the neck, so very close to the clavicle or the sternum. That incision is the Coker incision that goes from 6 to 4 centimeters. That depending on the thyroid volume or the surgery extension, but it goes around that. So this incision is pretty straightforward. It's the most common, the most used. I personally do not like this incision that much because it is very low. Sometimes with time, this incision can be brought down with the breast weight in women. I rather do the midline incision that runs over the midline skin crest. So this skin crest will after the incision is well healed and stuff, will be just over this crest and will heal perfectly, will resemble as a natural thing that has on the neck. And additionally, if you need to do a neck dissection, we can use that incision to extend that incision and get to the lateral neck. Do not need a J incision laterally that we usually do when we do those very low incisions that we talked about before. Well, having those incisions may not be a concern to everyone, but definitely is a concern to most people. Why is that? Because having an incision in the neck, uh, even have a beautiful incision in the neck. I'm not talking about those keloids or hypertrophic incisions that really calls to that, and we really get that to see that very rapidly. I'm talking just having a incision in the neck. So this beautiful paper published in 2020 by the Hopkins guys, they talked about how we perceive those incisions and how we gaze the patients when we are addressing them. So this is a uh, um, this is a program that is a uh, gets our attention and sees tracks our sight. So it tracks the eye movements, so they can perceive where we are looking at. So here in the right we have a woman, a brunette with a skin incision of a thyroidectomy. So we can definitely see on those circles that the incision keeps the gaze of the patient, the observer. And the people are talking to that patient and also looking into that scar like this, okay? On the other side, on the left patient, we also observe a small disturbance in the tracking, the eye movement, the tracking, just because of this mole here, okay? In the center, we have a patient without anything in the neck, okay? That patient, the site of the observer is just between the eyes and the nose. We really want, where we really want that uh, site and their attention to be. So we do not distract the observer like this. So it doesn't call any attention. And okay, this incision is important, but it's not only the incision that is important for this endoscopic approach. So here we see a regular thyroidectomy, and here we are observing the trachea like this. Here is a thyroid gland, also already moved to this over the trachea, and here we can observe the recurrent laryngeal nerve, and here the parathyroid preserved down here. On those surgeries, most of surgeons use magnifying loops that goes from 2.5 times to 3.5 in order to zoom the structures that we see, and those small structures can be well dissected, and we can be more comfortable while maneuvering those structures, okay, in order to preserve the thyroid nerve function and the parathyroid. The American Thyroid Association uh, really encourages us to use those loops to preserve the parathyroid functions. So it's already a thing that most surgeons are encouraged to do, okay? So we can really see that those structures are very delicate. Here, when we zoom the structure, the picture, we can really see that the nerve is very thin and the parathyroid is like is here. So for your comparison, the width of a regular recurrent laryngeal nerve is close to a paper clip. So we have in mind. So they're very small. When we talk on using endoscopic uh, instruments to do a open procedure, what are we really talking about? The OR is the same, the operating room is the same. Just one thing that is some things are different. For example, we do not use those ceiling lights that we use on open surgery. We use those monitors that are also close attached to the ceiling, and we do the surgery looking to the monitors, not to the patient itself. The patient's close, but we do the surgery looking into the monitor. Okay, we use modern and all the technology that are becoming more and more available to us. They are uh, addressed to endoscopic, robotic surgeries, intelligence, artificial intelligence, and augmented reality, things like this, all drive to those procedures that are endoscopic or robotic driven. Okay, and how do we do this? We use endoscopic instruments. So here we can see a loop. It's just it's a lens that we use. It's an optic that goes inside the patient that has a light and a lens in the tip. This is attached to a camera that is a full HD or it's a 4K camera or even 3D camera that we can use in this into the surgery. We have a console that will storage, will give up light, CO2, and have all these things that goes side to the patient. And the anatomy is upside down. As when we use the open approach, we make the incision in the bottom of the neck and we go up. When we use endoscopic approach, we make the incisions in the lip and we go from up to down. So our approach is inverse. So the anatomy is upside down. So the surgeon is need to be aware and be familiarized with this approach. Okay. We make 3 small incisions, one above the frenulum like this, and one to almost less than 2 centimeters in the frenulum, and 1 centimeter in each side of the lip. So, and we put the ports there, and we go below the skin and above the mandible, and we get to the neck. And when we get to the neck, when we make that dissection and move the muscles to the side, make incision in the middle of the isthmus, start dissecting the superior pole and make the dissection of the thyroid with those small instruments, and we remove the lobe while preserving the thyroid nerve and the parathyroids here, like this. After we do this procedure, so in short, just for comparison, here is an endoscopic view of a thyroid. Here I mark it in red so you can see the nerve like this. And here is the parathyroid. So you can have the proportion, right? This area here of the Maryland is 5 millimeter, it's a half of a centimeter width. The tip of the Maryland is 1.5 millimeter, just 1.5 millimeter. And here is the nerve, so we can glimpse how delicate and how small those structures are and how big you can see. So in this picture, I don't know if you're watching in the computer or in the cell phone or something like this, but we during the surgery we use 4K monitors, 42 inches or 42 inches or larger monitors that we put 1 arm of distance of our site, so we can really see these structures very large. After we do the dissection, we put the specimen inside the bag and remove the bag, so the pathologist in one side, so the pathologist can see the structures. So after the procedure, how a patient will heal is something like this. This is a view before the procedure. This is after the first day. He is the first week. Then this is the second week, and finally after the third week of the procedure. So we can really see that the patient will heal very beautifully, will heal very naturally, and the patient will can return to their business very quickly. Of course, some patients will have some bruises around the skin, but most patients won't have anything. This patient had a very large Graves' disease. So this is after before his first consultation with the speech pathologist. So we can see a little irregularity here on the skin, the chin, around the chin. After the second session, we can really see that this irregularity has smoothened and will be done very quickly. This guy had a very large goiter that we took care without incision. This is another lady after preoperatively and after the first day. This is the first day, and this is after the third day after surgery, like this. In conclusion, so what we can see this is that the absence of scar is something that many people will consider in the near future. So I don't think it's a matter of vanity or a matter of, don't know what if we want to call, but if we can do the same, we can do the same business, we can do the same surgery with a scar and without a scar, why not doing without a scar? So if the scar is a kind of problem that we create, you know, uh, we have to, we need to take care of the thyroid problem, okay, but we create another problem with the skin scar. uh, if we can avoid that safely, why not doing it? It's just a matter, why not? It's just a question. So we have a faster recovery. We don't need that much of a attention driven to the problem. People won't be asking what happened to your neck, what surgery did you do, things like that. Uh, we have the surgeon's perspective. So the scar and all that comes with the scar problem, or not having the scar, is, of course, it is important to the surgeon, but it's mainly the patient's concern and the patient's uh, drive for this surgery. But there are a lot of things that the surgeon take advantage of this surgery. So the zoom that we get with the surgery will help us, will make the surgery easier, will make the precision with the instruments, will make us do less mistakes as we get more comfortable with the procedure. So I think the procedure has advantages for the patients and advantage for the surgeon too. So it is a combination that is a win-win situation for both of us. So I think it is something that we may see a lot. And when we think about the future of surgery, of medicine, we are talking about artificial intelligence, augmented reality, that will merge technology, exams, pictures, 3D images inside the surgery, and will allow us to predict where the nerve is, where the parathyroid is, the extension of the tumor, everything uh, while we are doing the surgery. So a lot of this will be merged with the already existing technology. So this is won't be merged with open surgery. This will be merged with this new technology. So if we, the medical group wants to be a part of this new technology, it will have to adapt to a modality that can relate to this new technology. So it is a thing that we might need to take into concern in the near future. Okay. Thank you so much for your patience. I hope this can be useful to all you guys. I hope this pandemic will stop as soon as possible so we can meet again in person and have this the better feeling and understanding that we need. I hope you can get the chance to visit Rio. This is my city. Uh, this side is the Sugarloaf, and this side is the Christ. This is the Bay. I hope you have the chance to come here and visit us. I hope you are all safe, and thank you for this opportunity. Be well.